Okay, so we talked about infection, and now we're going to talk about how infections are treated. So really, the physiology of infection, there is a difference between the onset and the appearance of signs. So the incubation period is the time between the entry of an organism into the body and the appearance of clinical signs. And it's going to vary depending on the different organism. So the infection agent can be hanging out in the body for a while before you see any clinical signs. First, they have to gain entry to the body and choose the area where they're going to establish their colony and begin reproducing. So if that happens, but then the host defenses are sufficient to destroy all the pathogens, you will not have an infection. But if your defenses are insufficient to destroy all the pathogens, then the infection gets established. So the incubation period is when the pathogen is trying to establish its colony and overcome your defenses. So the prodromal period is the early symptom stage. That's the I'm coming down with something stage. Fatigue, loss of appetite, sort of non-specific symptoms. The prodromal period may be more evident in some infections than others. So some infections are insidious and they have a prolonged or gradual prodromal period, and some, the clinical signs appear quickly. So once the clinical signs appear, then that's considered the acute period. So the infectious disease has fully developed at that point. After the acute period subsides, then it's followed by a recovery or convalescent period, and the body process starts to return to normal. So a lot of times these infections are self-limiting, where the bacteria start to run out of nutrients, or the waste products from the dead organisms and necrotic tissue decrease the bacteria or the pathological agents' reproductive rate, and then you recover, basically. So of the infections that are self-limiting, it's important to know that you don't need antibiotics for every infection. So infections can take on different patterns, which are defined by their characteristics or location. So local infections, it's just the organism enters the body and remains confined to a specific location. Focal infections, on the other hand, the pathogen spreads from a local infection to other tissues. Once you start to spread through the bloodstream, through the circulatory system, then it can develop into septicemia, bacteremia, toxemia, or viremia. Anything with emia on it means blood. Septicemia is multiplication of pathogenic organisms in the blood, and the cause of sepsis, which is a toxic inflammatory condition caused by the spread of microbes in the bloodstream. Septicemia can kill you. So the other ones are just bacteremia's presence of bacteria in the blood, toxemia's presence of toxins, which might be produced by bacteria or viruses in the blood, and viremia is presence of viruses in the blood. So mixed infections are where several different infectious agents are established at the same site. So someone with decreased immune responses is more prone to mixed infections. So chronic infections have less severe symptoms than acute, but they persist for a longer period. So the primary infection is the first time you're exposed to a particular organism. So your immune system's like, what is that thing? Or we're not sure if it's bad, so we're going to see what happens. Okay? And then it starts to develop its defenses. Secondary infections are often subclinical. They follow a primary infection, so the second time this guy comes along, your immune system goes, oh, he's a baddie, we need to get rid of him. So a lot of times you have a subclinical infection. So there are no apparent signs because the immune system's like, I know how to deal with this one. So this is from page 105 in the book, and it talks about causes and development, and it's on a scale of time on the x-axis and the number of organisms on the y-axis. So different things can happen, different outcomes. So one of the outcomes is death. That's not good. Chronic infection is another outcome, or total recovery is really the one we want, right? So local infection, with infection, you often get inflammation. So we talked about this in the inflammation chapter. Inflammation is not necessarily caused by infection. There are other things that cause it. But usually you get those local signs: pain, swelling, redness, warmth. If it's bacterial, a lot of times you get a purulent exudate. If it's viral, you get the serous, clear exudate. Systemic signs: fever, fatigue, weakness, headache, nausea. With some viral infections, you have a subnormal temperature. So rather than having a fever, your temperature is running low. With severe infections, either viral or bacterial, the nervous system might be affected, resulting in confusion or disorientation, seizures, or loss of consciousness. So infections are serious. They could kill you. So in order to diagnose the infection, a lot of times they have to culture the infectious agent, and they have to test sensitivity, because diagnosis is one thing, treatment is another. So in order to effectively treat, you have to figure out what it is and what it's sensitive to. There are, so culture and sensitivity testing takes time. You have to grow that bacteria. With blood tests, there are indicators to confirm a diagnosis. Variations in the number of leukocytes, which are white blood cells. Leukocytosis means increased white blood cells. And that can be indicative of a bacterial infection. Leukopenia means decreased white blood cells, and that can be indicative of a viral infection. A differential count is they count the numbers of different white blood cells, and so different ones being elevated or depressed can indicate different types of infections. C-reactive protein and erythrocyte sedimentation rate are usually elevated with infections, and they're just a general indicator of inflammation. So the other thing that they can do, so here's some culture and sensitivity things. This is where they're figuring out how much of the drug it takes to kill the thing. So with the immunological testing of body fluids, they can identify antigens and they can identify antibodies. So actually finding the antibody to a particular antigen in the blood is useful for differential diagnosis. It's usually used for confirming a diagnosis, like, yep, there's the antibody. He's got to have that infection. So for drug therapy, it's not, I was saying earlier, it's not always necessary to use drugs to treat an infection, because the body's normal defenses are often adequate to limit the infection, or the growth pattern of the microbes is self-limiting. So once the colony uses up all of its nutrients and produces more wastes, it stops growing. So increased use of antimicrobials has resulted in increased resistance of lots of different organisms to certain drugs. So organisms can acquire resistance to drugs. So we're going to talk about this in our discussion this week. Drugs, antibiotic drugs particularly, need to be administered and taken as directed. They need to be taken until the prescribed medication is completely used or until a new drug is prescribed. If the symptoms continue without reduction, you have to talk to your doctor or pharmacist. You don't want to use drugs prescribed for other clients or other infections, because they might not be effective with the particular infection that you have. So it's not like you go, oh, I have this thing, and then now my husband got it, and I'm just going to use the same antibiotics the doctor gave me because I'm better. Well, drug resistance, the organisms, first of all, the antibiotic kills off some of the organisms. The ones that are left that you haven't finished your drugs yet, those guys are stronger. It's going to take longer to kill them. And so if you don't take all of your medications, you could end up with a resistant strain. And then you need multi-drug therapy, and that is bad news. That's why these superbugs need to be taken seriously. It's really a huge problem. So a lot of antibacterial drugs, they're grouped by sort of chemical classification and then sort of pharmacological action. We don't really need to know the details on this, but we need to know a little bit. So antibiotics are generally derived from organisms, like penicillin that's derived from mold. Originally that's what the antibiotics were derived from, but now there are also synthetic or semi-synthetic drugs, and they have to keep coming up with new ones because the bugs acquire resistance. Antimicrobial drugs, that includes antibacterial, antiviral, antifungal, they are usually species specific. Bactericidal drugs actually destroy the organisms. Bacteriostatic inhibits reproduction or relies on the host defenses to destroy the organisms. So you can have they can have different actions. When we talk about broad spectrum antimicrobials, that means they're effective against both gram-negative and gram-positive organisms. So gram staining is one way they use to identify organisms. Certain ones take up the dye in their cell walls and certain ones don't, and then certain antibiotics are effective with one or the other. Narrow spectrum antimicrobials are effective against one or the other, not both. So they classify drugs by generation, first generation and second generation. First generation referring to the original drug class like penicillin, the classic penicillin. Second generation refers to a later improved version of the same drug group. So the later version might be more effective, more tolerable, or more easily administered. Okay? So here's this broad spectrum antibiotic who's treating a variety of little bugs in its cage. So there are different modes of action. One of the modes of action that's possible is the antibiotic might interfere with bacterial cell wall synthesis. This is what penicillin does. It could increase permeability of the bacterial cell membrane. That's what polymyxin does. And our defenses can take it down more easily. It can interfere with protein synthesis. So that's what tetracycline does. And it could interfere with synthesis of essential metabolites, and that's what sulfonamides do. So different drugs have different actions, and different bacteria are more susceptible to one or the other. Antivirals, they can act in a lot of different ways. One way they can do is they can just block entry into the host cell. So however it is that the virus enters the cell, the drug blocks that. It can inhibit gene expression of the antivirals, so it can specifically target the accelerators that the virus uses to express its own genes, or it can inhibit assembly of the virus. Kind of neat. Antifungal agents, fungus are eukaryotes, like we are. So antibiotics do not work for them because those are meant for prokaryotes, okay? So antifungal agents might interfere with mitosis in fungi. They might increase fungal membrane permeability. So a lot of antifungal agents are administered topically, like the stuff you use for athlete's foot, that kind of thing. So fungi are eukaryotic cells, and so a lot of times the things that treat fungus are also toxic to animal and human cells. So you got to be careful with those antifungal agents because they can get your cells as well. Antiprotozoal agents, protozoa, are also eukaryotes, and so they have similar characteristics to antifungal agents. Many pathogenic protozoa have several stages of their life cycles, so they require treatment with different agents at different stages of the cycle.